Please register for CME as you have here. And just to highlight that we have obviously no grand rounds next week because of Halloween, which is weak. But I think the younger faculty really felt it was important, and I thought we should be encouraging of that. And then we have Dr. Nishimura here, who will be actually visiting with us, and in honor of Henry Cabin's visiting professorship, and a fellows lectures, and then Dr. Kirkpatrick after that. A couple of quick additional announcements. I just want to remind everyone that that I sent out a link to the Vice Provost's survey, and that Vice Provost is also our chair. So Gary would like us to do well and engage us in this activity. And he can't tell who did it, but he can tell which groups have done it. And I would say that I'd like to have cardiology be at the top of the department as relates to its representation. And the second announcement is just remind everyone that next Monday, and this we'll send out a reminder a little bit later this week, the Heart and Vascular Center is hosting kind of a social event meant to really help us connect with our colleagues in vascular surgery and cardiology across the system, in cardiac surgery and interventional radiology. And so I encourage everyone to go spend an hour and a half having some nice drinks and food and meet our colleagues that we haven't had a chance to meet with as much over the last several years. So that'll be next Monday, and again at Anthony's Ocean View, I believe. So with that, I'll ask Rohan to come up and introduce our speaker.
Thanks, Eric. Let me just see, it's being live streamed. Okay. Thanks for everyone who's here today. I appreciate that Halloween is a week when you leave, but I think it's hard to not trick and treat. So I hope people will understand. So today I have the immense honor of welcoming Dr. Tardif between us today, among us today. But with the he's done so much that I would not be able to do justice to his profile, but I would just say that, he is the research director of the Research Institute of the Montreal Heart Institute. And as a professor, is an endowed professor at the University of Montreal. And he has had a glowing career that has spanned work in mechanistic biological domains, but has crossed over effortlessly into large randomized clinical trials that have changed her practice, including the recent Colcott trial and how colchicine was incorporated into clinical practice. So I think it's an honor for us to be here, for us to host him. And then I would say that there are many listed honors that I could read out, but I think he mentioned that he would prefer that I don't. So, but I would say that he is a member of the Order of Canada, which is the highest civilian honor in Canada, and I think that deserves to be mentioned. And with that, I'm going to hand it over to you. Thank you.
Thank you so much. It's an honor, really, to be here with you today at your prestigious organization, and it's really been a great day. I've met great people, and I was impressed with the amount of work that is being conducted. And at the end of the day, I was privileged to see your imaging infrastructure platform, and I was blown away. So again, thank you very much for all the time that you have all spent with me today, the attendings, the professors, and the fellows. So I think I can skip this slide. So I'm going to take the next 40 minutes or so discussing the potential role of inflammation reduction in cardiovascular prevention. This talk is largely clinical. I'll have a few more basic or preclinical slides, but basically it's clinical because I want to discuss with you the potential impact of inflammation reduction. So basically, the last 2 decades have shown us that atherosclerosis is an inflammatory disease from its initiation, its progression, and its destabilization leading to acute coronary syndromes and strokes. Disease that involves, as you can see here, a number of cytokines, chemokines, different cells, lymphocytes, macrophages, and neutrophils. And actually, it's been approximately 20 years since the late Russell Ross published his major paper in New England Journal that some of you probably remember. Atherosclerosis is an inflammatory disease. So certainly this has been well characterized from the preclinical standpoint. As far as the relevance in the clinic of this, I want to start with a paper that was published in The Lancet a few months ago by Paul Ritker. Actually, I just learned that both the two people here actually were reviewers for that important paper. But let's suffice it to say, let's focus on the right part of the slide. This was a study of more than 30,000 patients, all treated with statins, patients with established atherosclerotic cardiovascular disease and or diabetes. And Paul Ritker asked the very relevant question: once you are treated with a statin, what is going to predict better events? Again, just look at the right part of the slide. Is it going to be lipids in white, LDL cholesterol, or is it going to be inflammation as reflected by high sensitivity C-reactive protein, hsCRP? These 30,000 patients were divided into increasing quartiles of both LDL cholesterol and CRP. And then you see the effect of LDL cholesterol, which once you're treated with a statin is at best modest. And you see that hsCRP predicts much better future major adverse cardiovascular events over the course of the next 3 years than LDL cholesterol. So this is for MACE. How about cardiovascular mortality? That result, I believe, is even more striking. You see again that CRP predicts much better future CV deaths than LDL cholesterol can once patients are treated with a statin. And what Paul Ritker and his colleagues did, he also separated or dichotomized these 30,000 patients into those that had well-controlled or not well-controlled LDL cholesterol and non-detectable or detectable inflammation by way of a CRP below or above 2 milligrams per liter. And the message of this slide, this is hazard ratios for cardiovascular death. And you see that if CRP is below 2, it almost does not matter whether your LDL cholesterol is controlled or not. The big difference is that once you have a CRP above 2, this is where the major increase in the future risk of, or the risk of future cardiovascular death lies. So the take-home message, in my opinion, of that study is that inflammation matters in patients with atherosclerosis and probably patients with diabetes. So if that is true, then the question is, how about if we try to lower inflammation in patients with ASCVD? So before going to patients, just one preclinical study that we conducted some years back, looking at one powerful anti-inflammatory agent that you all know and that you all use for gout or acute pericarditis, colchicine. We showed in a standard rabbit model fed with a hypercholesterolemic diet that when you treat these animals with colchicine, you see less inflammation in the arterial wall. And interestingly, you see a lot less of the deleterious outward or positive vascular remodeling that make these plaques unstable. So most of us here, I guess, are clinicians. So the question then is, how can that be translated into potential benefits for our patients? So this is a summary that dates back now 3 years that Peter Libby and I published in Pure Heart Journal of the status of the literature at that time of clinical trials of different anti-inflammatory therapies that had been tested in patients with cardiovascular disease. So if we start with line number 2, this was really a major paper, the CANTOS trial that Paul Ritker ran, a study of 10,000 patients with monoclonal antibody to interleukin-1 beta, canakinumab. So this is pure inflammation lowering without impacts on lipid. And what was shown in that study of patients that had suffered a myocardial infarction is that there was a 15%, 15% in the risk of future cardiovascular events by the addition of canakinumab compared to placebo. Then Paul Ritker went on to conduct the CERT trial, the cardiovascular inflammation reduction trial, a study of close to 5,000 patients that was stopped prematurely for futility of low-dose methotrexate that not only failed to show benefits on events, but in that study, low-dose methotrexate also did not alter inflammation-related biomarkers. So two large studies that did not show the same effect. One that yielded positive effects, canakinumab, the drug that is obviously an injectable, that is very expensive. And in the CANTOS trial, there was a small but significant increase in the risk of septic shock. So we all know as physicians, when we give drugs, there are some benefits, but often there's a price to pay. When we give antiplatelet agents, anticoagulants, we provide benefits, but often patients bleed. So the question was, when we will start to alter inflammation and or immunity, are we going to pay a price in terms of infection? So we looked at that, and I'm going to review that with you in a minute. So there have been two large studies that have tested an orally administered drug, colchicine, a drug that to this date is known to have only one target, one protein target, which is tubulin, which is the structural protein in microtubules involved in the motility of white blood cells and the proliferation of white blood cells. So there have been two large studies, COLCUT and LODOCO2, and I'm going to review that with you. So the first one that was conducted was called COLCUT, which stands for the Colchicine Cardiovascular Outcomes Trial, a study of 4,700 patients recruited within 30 days after a myocardial infarction. These patients, as you can imagine, were taking all the good drugs that they should be taking, antiplatelet agents, statins, and so forth, were treated according to national guidelines, and percutaneous coronary intervention was completed if deemed necessary by the treating physicians. And then patients were randomized to low-dose colchicine, 0.5 milligrams once daily, or placebo. The primary efficacy endpoint was the composite of cardiovascular death, cardiac arrest, MI, stroke, or urgent hospitalization for angina requiring coronary revascularization. So to give you a feel for the type of patients involved in COLCUT, mean age 61 years. Unfortunately, a minority of women in that study. Hypertension was present in half of the patients, and diabetes present in 20% of patients. Probably a bit more important than this, the interval between myocardial infarction and randomization was 13 days, or approximately 2 weeks. PCI was conducted for the index myocardial infarction in 93% of patients. And the standard of care was very good. As you can see here, aspirin was being used in 99% of patients, a second antiplatelet agent in 98% of patients, and a statin in 99% of patients. That was the primary result of COLCUT. As you can see here, a 23% relative risk reduction in favor of colchicine compared to placebo. So the hazard ratio was 0.77, the p-value of 0.02. And you see that the curves diverged actually very early in favor of colchicine in a matter of a few months. With more granularity, you see here the first line that is underlined, the absolute risk reduction was 1.6% after 22 months of follow-up. And then the next 5 lines show you the effect on the 5 components of the primary endpoint. And here you have the point estimate of the hazard ratio for CV death, 0.84, for cardiac arrest, 0.83, for myocardial infarction, 0.91, for stroke, 0.26, and for urgent hospitalization for angina requiring revascularization, 0.50. So the point estimate was on the right portion of the unity line for all 5 components. So colchicine appeared to favorably affect all components, but for some reason it affected more stroke and urgent hospitalization for angina requiring revascularization. I'll come back to that in a minute. We had pre-specified in that study that we would also look at the per protocol population of patients that would exclude patients with major protocol deviations, including patients who would not be taking their drug. We did that because at that time when we started in 2015 or 14, we did not know how would long-term colchicine therapy would be tolerated. And so we did want to look at if patients were taking their drug, what would be seen. And there was no pre-treatment period, unlike low-dose O2, where everyone was treated with colchicine before the randomization part in COLCUT. So the per protocol analysis showed a 29% relative risk reduction when patients were taking their drug. And again, when we did that analysis, the absolute risk reduction was larger, 2%, and the effect on MIs was a bit more marked than in the previous analysis. So obviously, I've presented up to you the classical way of presenting data, the time to first event, but from the patient perspective, from the family's perspective, the payer's perspective, it's obviously not the first event that only matters, but I believe it's the total burden of both first and recurrent events that matters. And so we had also pre-specified that we would indeed perform a recurrent event analysis in COLCUT, and we had pre-specified that in red we would use the negative binomial model as the primary analytical approach. And when we did that analysis, there was a 34% relative risk reduction in the total burden of first and recurrent events with colchicine compared to placebo. And to this day, I think there has not been another agent that has provided such a large relative risk reduction on top of aggressive statin therapy. Now, turning to safety and tolerability, if I was going to make a joke and I ask you the first word that, the first word that comes to mind, if I tell you a word, if I said colchicine, you would probably all say diarrhea, right? So this COLCUT study, 4,700 patients, was conducted with a lower dosage of colchicine, 0.5 milligrams, and it was an extended form of colchicine. I don't know if that affected the result, but we were actually fairly pleasantly surprised that the occurrence of diarrhea in COLCUT was not significantly different with colchicine, 9.7%, than with placebo, 8.9%. That difference was not significant. What we did see was a small but significant increase in nausea, 1.8% with colchicine, 1.0% with placebo, and that difference was significant. We were also, as I said earlier, interested in looking at infections in that study. While the occurrence of infections, all types of infections, was not significantly increased, there was a small but significant increase in the occurrence of pneumonia that occurred in 0.9% of patients with colchicine and 0.4% with placebo. But unlike what was observed with canakinumab, there was no increase in septic shock, 2 cases, both in the colchicine and in the placebo arm. I'll come back to that when I discuss the other studies and meta-analyses. The final point I'm going to say about COLCUT is that sub-analysis that we've conducted I want to acknowledge my young colleague, Nadia Abdalawi, that basically put forward the hypothesis, well, if atherosclerosis is a chronic inflammatory disease, and if acute myocardial infarction is an acute exacerbation of a chronic inflammatory process, how about if we treated patients even earlier after myocardial infarction? So all that is here is a subgroup analysis. So I guess to a certain extent should be taken with a grain of salt. But when you see here, TTI, it stands for time to treatment initiation. So that if you take the subgroup of patients where we randomize them within 3 days, so patients that were randomized before they were discharged after myocardial infarction, again, this is a subgroup analysis, but the effect appeared to be even larger. And the benefit appeared to emerge after only a month of therapy. So just food for thought. So we were happy that hopefully we had made a contribution as to the clinical relevance of inflammation reduction in patients with ASCVD. We were very excited when a year later, the Australian investigators, the LODOCO-2 investigators led by Mark Neidorf, published their results of LODOCO-2. We believe that LODOCO-2 complements very well COLCUT. So again, COLCUT, 4,700 patients recruited within 30 days post-MI. LODOCO-2, 5,500 patients with stable CAD. Again, what I mentioned earlier, a difference compared to COLCUT, these LODOCO-2 patients entered a 30-day run-in period, and they were randomized only if they were tolerating colchicine well, to 0.5 milligrams per day or placebo. In terms of baseline characteristics, patients were a bit older in LODOCO-2, 66 years versus 61 in COLCUT. Again, a minority of women. Half of the patients had hypertension, 20% of patients had diabetes. In terms of concomitant therapies, obviously DAPT, dual antiplatelet therapy, was used less often in LODOCO-2 because these patients were stable. So DAPT used in 98% of patients in LODOCO-2, in COLCUT, 23% of patients in LODOCO-2. Statins used in 99% of patients in COLCUT, 94% of patients in LODOCO-2. So standard of care was very good. And we're really excited when there was finally a second study that showed basically the same thing, a 31% relative risk reduction in the incidence of the primary endpoint with low-dose colchicine compared to placebo. And once again, the curves diverge fairly early in favor of colchicine versus placebo. This is the primary endpoint. As you can see here, the composite of CV death, MI, stroke, or ischemia-driven coronary revascularization. In terms of the key secondary endpoint, the triple hard endpoint, CV death, MI, and stroke, a 28% relative risk reduction with colchicine compared to placebo. And in terms of a number of ranked secondary endpoints, I'm not going to read all of that for you. Perhaps we can focus on lines number 3 and 5. Line number 3, the composite of CV death or myocardial infarction reduced by 29% by low-dose colchicine compared to placebo, p-value 0.01, and all fatal or non-fatal myocardial infarction on line number 5, a 30% relative risk reduction, again with a p-value of 0.01. In terms of stroke, a trend for a reduction with colchicine, but the numbers were small and the difference was not significant. So why the effect of low-dose colchicine appeared to be more marked on stroke than MI in COLCUT and more marked on MI than stroke in LODOCO-2 is not entirely clear in my mind. There were two differences. Patients had a recent MI in COLCUT. 98% of patients in COLCUT had received dual antiplatelet therapy, whereas only 23% of patients received DAPT in LODOCO-2. Whether or not this had an impact on the difference is not entirely clear. In terms of the effect on death, CV death, and non-CV death, you see, and I'll come back to that when I discuss the meta-analyses, you see a non-significant effect on death, and you'll see in other slides that is the summation of a trend for a non-significant trend for a decrease in CV mortality and a non-significant trend for an increase in non-CV mortality. I'll come back to that in a minute, without any particular pattern in terms of new cancers, infections, and specifically pneumonias. So that's what we had after two large trials, COLCUT and LODOCO-2, both published in New England Journal. Since then, there have been at least 5 meta-analyses of all colchicine studies in coronary artery disease. They pretty much all show the same thing. So allow me to use our meta-analysis. I want to acknowledge a young colleague, Michelle Samuel, is a PhD epidemiologist that just joined us at the Montreal Heart Institute. Here is the primary composite endpoint of our meta-analysis. You have the components, CV mortality, MI stroke, and urgent coronary revascularization. In that meta-analysis, a reduction of 32% with colchicine compared to placebo. The next 4 slides are going to all be coming from that same meta-analysis. All you have to do is look at the second line of the title, which will point to the endpoint of interest, and then you can look at the point estimate of the effect. So the next slide will be the effect of low-dose colchicine on myocardial infarction. In that meta-analysis, a reduction of 38% with low-dose colchicine compared to placebo. Ischemic stroke, a large reduction of 62% with low-dose colchicine compared to placebo. And then urgent coronary revascularization were reduced by 44% with colchicine compared to placebo. And then the triple endpoint CV death, MI, and stroke was reduced by 22% by colchicine. Again, bear in mind, all these patients had an aspirin, a large number of them had DAPT, and on average, 97% of patients were receiving a statin. Now, hopefully up to now, I've convinced you that colchicine reduces non-fatal CV events. How about mortality? So there has been a lot of discussion or some discussion about this. I want to review it with you. In the meta-analysis, colchicine had a neutral effect on all-cause mortality with a risk ratio of 1.04. That again, that is the summation after 22 months of follow-up for a non-significant trend for a reduction in CV mortality and a non-significant trend for an increase in non-CV mortality. But at the end of the day, the effect on all-cause mortality was neutral. With more granularity, no effect in the meta-analysis of colchicine on infections, pneumonias, hospitalizations for GI events, and importantly, a neutral effect after about 2 years of therapy follow-up on diagnoses of new cancers. We've reviewed all of these data in great detail in Circulation a couple of years back. So all of these data, LODOCO-2, COLCUT, the meta-analyses, I believe were the reason, the basis for regulatory approval, both in Canada and the US. Health Canada approved colchicine, low-dose colchicine for secondary cardiovascular prevention. Let me read their words. extended release colchicine is indicated for the reduction of atherothrombotic events in adult patients with existing coronary artery disease, in addition to standard therapies, including LDL cholesterol lowering and antithrombotic drug treatment. Health Canada, and I'll come back, the next slide will be from the FDA. Health Canada reminded us that colchicine is contraindicated in patients treated concomitantly with strong PGP inhibitors or CYP3A4 inhibitors. The classical example is clarithromycin, Biaxin. Importantly, you can use colchicine with azithromycin. Probably the most important guidance is the second one. Colchicine is contraindicated in patients with severe renal impairment, and as well as in patients with severe hepatic impairment. What I think is important to know is that once you understand to stay away from patients with severe renal impairment, and in particular, if they treated with concomitant medications like a strong CYP3A4 inhibitor, colchicine is well tolerated and safe. The final point of that slide is from me, because I still hear from time to time internists or cardiologists say, oh, I thought that it's not safe to use concomitantly colchicine and high-dose statins. This is incorrect. As per the 99% of patients treated with a statin in COLCUT, the 94% of patients treated with a statin in low-dose 2, you can use low-dose colchicine with high-dose statins for cardiovascular prevention. So, without being too facetious, that announcement by Health Canada had no impact around the world. Then the FDA announced in June 2023 their approval for the first time in history of an anti-inflammatory agent for cardiovascular prevention. And this is not a joke. Then I got, I think, 12 invitations from US universities to start discussing this. So this is the label from US FDA. Colchicine, low dose, 0.5 milligrams once daily, is indicated to reduce the risk of myocardial infarction, stroke, coronary revascularization, and cardiovascular death in adult patients with established atherosclerotic disease or with multiple risk factors for cardiovascular disease. So a very wide indication. They too, as expected, and as they should, reminded all of us that the concurrent use of strong CYP3A4 inhibitors or PGP inhibitors with colchicine is contraindicated, including or particularly in patients with renal impairment. So 2023 has been a busy year for inflammation reduction in colchicine. So the first two parts of the slides I've discussed with you, Health Canada and FDA approvals. And in 2023, both the European Society of Cardiology guidelines and the ACC/AHA guidelines have allowed colchicine to enter the guidelines. I would like to tell you, as a class 1 indication, we're not there yet. I think it will change over the next few years. But I'm glad to say that the ACC has given a recommendation in patients with chronic coronary disease. The addition of colchicine for secondary prevention may be considered to reduce recurrent ASCVD events. I use it more wisely, but I think it is a step in the right direction. What do I think? The next slide will say in conclusion, but it's not my last slide. But this is an editorial that the GACC editors asked me to write with my young friend, Guillaume-Marie Gravel, who trained at Duke, by the way, 2 years ago, but I think these words are still true. In conclusion, low-dose colchicine reduces the risk of ischemic cardiovascular events on a background of excellent standard of care, irrespective of whether the patient has had a myocardial infarction or presents with stable coronary artery disease. In light of the positive results from LODOCO-2, COLCUT, and meta-analyses, its good tolerability profile and cost effectiveness, I haven't shown this in this presentation, but colchicine is economically dominant. Inflammation reduction with low-dose colchicine should be considered. I'm not saying given to everyone, but at least should be considered to treat patients with coronary disease in the absence of severe renal disease. So usually at this stage, people tell me why, tell me, JC, if these data look pretty good, why is it not affecting our algorithms of practice? Well, I think we need to give time to time. First trial in statins 4S did not change practice overnight. I think there's an element, that's my editorial comment. I'm looking forward to your comments in a few minutes. There are a lot more people pushing SGLT2 inhibitors and GLP-1 receptor agonists and PCSK9 inhibitors than people actually talking about colchicine. And so there's that. There's probably a bit of that. Paul Ritker says that all the time. And then let me play the devil's advocate, because I hear these points all the time. Again, I want to be a bit provocative. These are my editorial comments, and I'm looking forward to your comments. Sometimes I hear, well, JC, 23% relative risk reduction in the primary endpoint. Is it that impressive? I have no problem. Someone wants to tell me that's not that impressive. Well, I just want to, and I stole that slide from Paul Ritker, who published just a month ago a wonderful review in GACC with Val Fuster. So this is in that paper. I think this is fantastic. I have no problem if someone wants to tell me that 23% reduction is not impressive. But then when people say this, I say, well, maybe you should review your use of PCSK9 inhibitors, because this is just side by side. Drugs that you can use on top of statins, ezetimibe, and this is not bad mouthing anyone. These are just facts. The two PCSK9 inhibitor studies, Fourier and Odyssey, and then the two colchicine studies. So, let's just average this out, 27%. I think it compares pretty favorably to the two great PCSK9 trials with evolocumab and alirocumab. All right, then some people say, well, it's not the relative risk reduction that matters. It's the absolute risk reduction that matters. All right, good. And then if someone wants to say, well, I'm not terribly impressed by a 1.6% absolute risk reduction by that drug, say, fine, that's a legitimate argument. I just want to have a reasonable playing field here. Again, 5 same papers, all published New England Journal. This is the absolute risk reduction you get by a PCSK9 inhibitor. This is not a question of bad mouthing. I give PCSK9 inhibitors all the time. I run the genetic clinic for lipids at the the Montreal Heart Institute. I just want to put that side by side. And then the final point I hear is, well, you don't lower mortality. So, and then when somebody says that, I said, well, that's a legitimate concern. If you don't give a drug, if it doesn't lower mortality, that's fine. But then I say, well, maybe you should go back to the PCSK9 inhibitor studies in New England Journal, because they too did not lower mortality. So I just want, I have this difficulty for several of the arguments of not considering inflammation reduction as a new pillar of therapy. Anyway, the data are here. And then the final point I hear sometimes is the issue of non-CV death, the trend for increase in non-CV death after 2 years of therapy. What we have is a drug that is inexpensive, colchicine, in meta-analyses lowers MIs, strokes, revascs by more than 30% and has a neutral effect on all-cause mortality. And I say, since when is it not relevant to prevent MIs and strokes? So this is my editorial comment. So just before closing, in the last 2 minutes, I want to go full circles and come back to that great paper from Paul Ritker from a few months ago. So the data that showed that CRP predicted better future events than LDL cholesterol. And these are not my words, so I'm doing that on purpose. Paul Ritker said then, given that paper and other evidence, following statin therapy, should we clinicians elect to use a second lipid-lowering agent, or choose instead, or start at least considering to choose instead to use an anti-inflammatory agent? And Paul's answer to that was at least start considering low-dose colchicine for those with stable atherosclerosis and normal kidney function. So I was fortunate when that paper was published to be asked, I have only two final slides, so I'll be done in 2 minutes, to write the editorial about what these data mean from Paul's paper. And I want to address one final point. My patients, not uncommonly, tell me, oh, doctor, you don't want to add yet another drug. So the issue of polypharmacy. And I do hear that when I talk with my cardiology colleagues, internists, and so forth, my patients don't want to take another drug. Well, I'd like to understand something. When we turn to another field, heart failure, there are 4 treatment pillars. And if we don't use these 4 treatment pillars, we're basically seen as a bad physician. If you don't use your beta blocker and your Entresto, your MRA and your SGLT2 inhibitors. Why is it that then, when we start talking about the drug that kills even more people, a disease that kills even more people, ESCVD, why are we more concerned about polypharmacy? So I think, in my opinion, and that's what I've underlined here, I believe we should no longer consider intensive lipid lowering and inflammation reduction as mutually exclusive, but rather as complementary approaches in patients with ASCVD who are already receiving statin therapy. So all of my discussion was about secondary prevention, patients with established disease. How about prevention, primary prevention? That at least 2 people that mentioned that in the discussions I've had today. And I'll leave you with one thought about the future. We've just launched 4 or 5 months ago a primary prevention trial called COLCUT T2D, a study of 10,000 patients with type 2 diabetes, but this time without known coronary artery disease. I will not bore you with the other aspects of the trial. It's a factorial design study, but we will be testing whether low-dose colchicine in primary prevention can prevent heart attacks, strokes, and we will start going into trying to see if we can affect cognitive impairment as well. So stay tuned. It's going to take 4 or 5 years. I thank you for the attention, and thank you so much. I'm honored to be here with all of you today. Thank you for your attention.
Maybe ask the first question while people are getting their thoughts together. JC?
Yes.
What I appreciate and talking a lot about the status of the data versus the outcomes. So I'm going to ask you to help educate me a little bit on. You mentioned this concept of the effect of the two. And if you could just help us understand how OCC works as an anti-inflammatory.
Yes, that's a great question. So the person I believe that, and I certainly do not want to insult anyone, but one of the persons that knows colchicine best in the world and knows microtubules works at the NIH, and his name is Dan Sackett. So Eric, I've asked the same question to Dan Sackett. So what I think we know, one thing we do know is that colchicine affects the prolongation, the elongation of microtubules. That we know. Then we know that there's an interplay between microtubules and the inflammasome. That there's data showing that. The detailed mechanisms for that interplay between microtubules and the inflammasome, to the best of my knowledge, has not been entirely clarified. As you know, microtubules, yes, they are involved in the motility of white blood cells. They're involved in the proliferation of white blood cells, but I certainly didn't want to sound too simplistic. They're also shuttling all sorts of molecules within the cells, orienting them towards different parts of the cells. So I apologize for the long answer, but what strikes me about colchicine is that it is not only preventing ischemic events, it's also obviously very good in gout. What is one potential common denominator between gout and atherosclerosis? They are crystal-related diseases. Urate crystals in gout, cholesterol crystals in atherosclerosis. And that might offer a clue for what is happening. There are some unpublished data from us and other groups that clearly show that if you block the effect of microtubules, you affect the function of the inflammasome. The reason I'm saying that, then that what I think we also know is that there are multiple inflammatory pathways. To some extent, they're redundant. But up to now, I think what we know is that the inflammasome / IL-1 / IL-6 pathway probably appears to be the predominant pathway in patients with atherosclerosis. So I'm not giving you a full answer, but there is an interplay between the inflammasome and the microtubules. And actually, I think within the next 2-3 years, we'll understand a lot better at the molecular level what is happening. And I think there'll be new drugs affecting that interface. And actually, some companies are starting to work on this. Sorry for the long monologue, Eric.
That's great.
Yes.
I don't have just to. Thanks. Is it on? Okay. Just to add onto that a little bit. So one of the sort of famous roles for microtubules is to orient what's called the MTOC, the microtubular organizing center, and
Yes.
it orients the Golgi apparatus, right? And so they're very involved in secretion.
Absolutely.
Very, very involved
Absolutely.
in secretion. Probably even more so than migration. And so I wonder what happens to IL-6, IL-1, TNF, all the cytokines that have to be secreted. I mean, you mentioned the inflammasome, so obviously production of mature IL-1 may be an issue, but what happens to those guys in the presence of colchicine, their systemic levels, and what happens to CRP for that matter, which is probably driven by
Yes,
IL-6?
great question. So there are things that are, we don't understand everything about colchicine. And it's strange because, as you know, the Greeks thousands of years ago were chewing on this and realized that it was affecting gout 3,000 years ago. And yet we don't understand everything. So it is strange because it appears clearly to affect the inflammasome, I think through the effect on microtubules. To answer your question, not in cold cut because we did not do that, but when you give colchicine, CRP goes down by about 25%, IL-1 and IL-6. But other, it's sort of a quote unquote, not a clean drug in the sense that it has effects on multiple inflammation-related biomarkers, IL-18. So you could say, well, yeah, but it's still in the inflammasome, but even other chemokines and others. So we don't understand everything. There is, and then, your next logical question, which should probably be, well, is it about production or secretion? I cannot give you that answer. But the effect is not only on the inflammasome.
Thank you. It's great work.
Oh, thank you so much.
Yeah. So, best is for folks on the call. On the call.
Fine. Question I had, you showed some good data showing that the CRP levels are more predictive than the cholesterol levels in the people who are
Yeah.
treated. In either your studies or the other studies, is there any evidence that the baseline CRP level at the initiation predicted who would benefit? So like the higher CRP people seem to do better
Yeah.
with colchicine?
It's a great question. I would like to tell you, here's the answer. We did not do CRP measurements in the 4,700 patients in cohort 1, only a small subset of patients. There are at least 2 reasons for that. There's a scientific reason, and there's a much more practical reason. And I'm going to give you both. I could be probably more elegant and tell you, well, cold cut patients were recruited 13 days on average after an MI. So as you know, there's a major peak of CRP at the time of an MI. And then whatever you do, the natural history is that it comes back to baseline 3 weeks later. So we thought in cold cut, that was not the right study to measure CRP at baseline. So there is a scientific rationale for not having done that. The other very mundane reason is that when you start doing studies of 5,000 or 10,000 patients with a drug that costs in Canada 25 cents, there are not that many pharma companies that are willing to help you. And so what we did is that we had funds from Canadian NIH that we call CIHR and philanthropic funds. So we had difficult choices to make. So if there are some young trialists here, you have tough choices to make. We wanted to provide a reliable answer on the first question about events, and we did not do detailed biomarker work. They did a bit more in LODOCO2. They did some proteomic analysis, and that's why I was alluding to. There was a CERC paper from LODOCO2. They did see effects on multiple inflammation-related biomarkers. In CoCut, in CoCut T2D, we already have, I'm proud to say we've already have received 4 grants from CIHR, from Canadian NIH. So we will have biomarker data in 8,000 patients, but it's going to take 4 to 5 years. Sorry. So I don't have the full answer for you. I'm going to repeat the question that you're going to ask.
Very nice. I have 2 questions.
Yes.
The first one is, how do you define inflammation? So in regards to injury, trigger, both one and 2 type of response. How do you define it? How do you define CRP,
Okay. The question was, it sounds simple, but it's absolutely not. And I don't want to look like an idiot in trying to answer that question that is from an experienced person. So the question is, how do you define inflammation in the context of atherosclerosis, of heart disease? So there are different ways of defining inflammation. If you are a molecular biologist, and you work in atherosclerosis or vascular biology, I guess you define it by saying there are increased levels of adhesion molecules expressed at the surface of the endothelial cells. You have more chemokines attracting white blood cells. You have more white blood cells in the arterial wall, and then you can measure white blood cell proliferation in the arterial wall. So if you're a molecular biologist, that's how I guess you define it. And then you go further, you inactivate certain genes using small interfering RNAs or ASOs, or you knock down a gene and you say, by inactivating an inflammatory pathway, I have a benefit. So that's, I guess, the definition that a molecular biologist would have. If you are an epidemiologist, you say, if I collect 50,000 patients, those that have a higher CRP level have more MIs and strokes. And if you are a clinical trialist, I guess if you affect that pathway and you have effects on clinical outcomes, you say that is as relevant. So I guess there's more that you're absolutely right. I'd like to hear in a minute what your definition is, but I guess there are different ways of defining inflammation at the molecular level, at the cell level, at the animal model level, or at the human model.
Can you, I don't have
11, we've been working on imaging inflammation.
Yes.
cardiovascular pathology
Yes.
for 20 years.
Yes.
And the issue that 30 years imaging because
Ah, oh, I see what you mean now. Okay. Okay, now I understand because you mentioned the word imaging. So I guess if you, and you know, I'm not an expert at this, but if you do FDG PET imaging in an animal model or in human beings, I guess you're not measuring glucose metabolism of M1 macrophages. You're looking at glucose metabolism of all white blood cells, and it might be M2 anti-inflammatory macrophages. So I agree with that statement.
second question I have is about revascularization.
About?
Revascularization.
Yes.
I assume in many of these patients, they underwent revascularization and then they were readmitted for angina and vascularization. So many of the events, half of the events that happen after revascularization, the artery that was vascularized. In your data, where were these events that happened?
Yes. So the question was in cold cut, when we talk about coronary revascularization, and these patients had PCI for their index myocardial infarction, and these data, the answer to your question is not in the New England Journal paper, but I can give you that answer. So the question was, were coronary revascularizations predominantly in the target-related artery or in a remote artery? And in the vast majority of cases, it was in a non-stent related artery. So we looked at that. And it's funny, the real story is the New England Journal reviewers asked for that question. I gave the answer, and the editors, because we have these 2,700 words, decided not to add that answer in the paper. Oh, sure.
Questions from online? Sure. Got a screenshot for them already, so I might just ask. So Tony's asking about the idea of using HSCRP in the primary prevention study. So both questions we had, one from Tony Giamo, the primary prevention cardiologist in our practice, and Sean Parikh, who's a cardiology fellow, about two questions about the use of targeted primary prevention, the lack of doing inflammatory testing, and for HSCRP, for example. And second, the use of aspirin, is it 40 milligrams instead of 81?
I didn't want to get into that, and
Yeah,
people are going to throw tomatoes at me or tomatoes at me in a minute. So let me add, because this was about inflammation, I'll start with inflammation, and maybe I should have hidden aspirin there. It's a distraction. I'll say a few words about aspirin in a second. So inflammation, targeted therapy, precision medicine, and so forth. I did not, because the talk was about the data we have generated, not about the future, I did not give you all of the design characteristics of cold cut T2D. So it's not only 10,000 patients with type 2 diabetes, but it's 10,000 patients with type 2 diabetes and at least one high risk characteristic. So either they have long-standing diabetes, a high CRP, a high triglyceride level. We have like 10 or 12 characteristics. So we have enriched the population. It's not only type 2 diabetes, it's type 2 diabetes plus. So I guess that answers that question. And if someone wanted to say, and Paul Ritker is a major proponent of that, and that makes a lot of sense. He's saying, I'm not going to give inflammation reduction therapy to everyone. I'm going to focus on patients with high CRP. I think that's fine. Mark Nidor from Lodoco 2 and myself are saying, well, we did not segment the population according to CRP. So we would use it more widely, but I think that would be a good start. As far as, again, maybe I feel bad, maybe I should not have shown that slide. Why we are revisiting aspirin. This is just a hypothesis. So the story of cold cut T2D, the backbone was inflammation reduction with colchicine in primary prevention. Then my younger colleague, Guillaume Marquis-Gravel, who was trained at Duke for 4 years and was involved, what's the name of that study, aspirin, adaptable, and so came back, and I'll tell you the real story. He said, we need to revisit aspirin, and there's data showing that enteric coating of aspirin reduces your absorption. And then there's data also suggesting that the turnover of platelets in diabetes is much faster than in patients without diabetes. And then I have to admit, when we designed this, I don't know, 18 months ago, I was skeptical. And I thought that what I was taught at med school 30 years ago was aspirin inhibits irreversibly cyclooxygenase, and the half-life of the platelets is 7 days. So I told him, well, that doesn't make sense. And then he reminded me that while platelets do not have a nucleus, they have a lot of mRNA. So if you have aspirin that has a half-life of 6 hours, and you have platelets in patients with diabetes that are turning over a lot faster, he generated that hypothesis that maybe we should revisit, following the disappointing results of entry-coated aspirin, 80 milligrams once daily, and ASCEND and the other large trials, that we should try to revisit non-entry coated aspirin, 40 milligrams twice daily. And to his credit, we're testing this, and it's just sort of the secondary hypothesis in that fractorial design. So we'll have to see what it shows.
Maybe one more question for Margaret. You want to read it, and then we'll close out. We have stacks, and there's hopefully opportunity for people to
I'm always confused.
ask questions here after the topic finalized.
Sorry, I'm trying to figure out where the comments went. So,
Margaret, do you guys want to unmute yourself and
Yeah.
ask the question?
that might be best.
She's going to show a slide.
No. The issue is that I can't see the chat.
Yes.
Hi. All right. I just figured out how to unmute myself. Dr. Tardo, I was curious given the secondary prevention benefits of colchicine in coronary artery disease, do you believe the data could be extrapolated, or did you guys at all look at its benefit in peripheral arterial disease as such in the carotid artery beds or the lower extremity arterial beds?
Yeah, thank you very much for the question. The question was, do I believe? The answer is, I believe that it is going to work in peripheral artery disease. Should we extend it and treat all patients with peripheral artery disease now? Then I think I would be a bit more reluctant because we don't have the data. That being said, there is COCA T2D in primary prevention that is being conducted. And there is a study that will be starting in a few months. I believe that is, I forget the name of that study, but it is 8,000 patients with peripheral artery disease testing low-dose colchicine. And what I would add in COCA T2D, I believe that we'll have at least a third of patients with peripheral artery disease. So we'll have at least 3,000 patients, but it's going to take a few years. But do I believe that it's going to work? Absolutely. I think actually patients with peripheral artery disease have the disease. They have inflamed arteries, and I think it is going to work.
Well, everyone, let's join in thanking JC for spending the time with us. Ron, if you have any questions that you get to answer,
Thank you so much.
Really didn't know. I
would have asked it.
Oh, thank you so much. That was a privilege. Good.
A little bit less.
That's